discussion. Yeah, welcome back from the lunch break to our symposium. And now we have a number of presentations which are focused on the research which was done within the DigiMed project. And the highlights have already been mentioned in the morning session. And the first presentation is about the HerzFit app, and it's a presentation shared by two. One computational or a digital medicine scientist, which is Lara Reimer, and Fabian Starnecker. He will start. He is a cardiologist, and he will present the feature of the app, the risk prediction. Maybe you can come together and share your presentation. You can. We have also enough microphones.
Okay, thank you for the introduction. The two of us would like to speak a bit about cardiovascular prevention now. And we would like to do so because we all do know that prevention is quite important. And we do know that we could prevent many cases of cardiovascular disease just by living a healthy life and effectively controlling our risk factors. But the truth is, we also do know that we are not really good at preventing disease. So the question is, why aren't we better at preventing cardiovascular events? And maybe do we need to raise more awareness for cardiovascular prevention? And when we thought about this, we first of all realized that we needed a partner, someone who already has been engaged in cardiovascular prevention. And back in 2019, out of a reason, we contacted the German Heart Foundation. The German Heart Foundation is one of the largest patient member foundations in all across Europe. And for many years, they have been very engaged in informing people about cardiovascular health and disease. And amongst the material that they present or give to laypersons, there is a risk assessment test. And this test allows laypersons to check whether they have an elevated risk for a heart attack or not. And in the very first step of our cooperation back then, we updated this tool. And we then kept on thinking about how to deliver this tool to the population and how to deliver further preventive materials to them, especially in a more and more digitalized population. And that was pretty much the time when we came up with the idea of developing an app. And now, a few years later, this app is called HerzFit, and we have been developing it together with the German Heart Foundation and also the German Hypertension League and the Techniker Krankenkasse. So lucky you, we're going to spare you with all the technical details from that time, but still, Lara would now like to give you at least a bit of an impression of what HerzFit now looks like.
So, thank you. After those 2.5 years that took us for the development time of HerzFit, that included a lot of development, of course, and internal and external testing, we finally released HerzFit in April of 2022. We scheduled the release to be part of the Hand aufs Herz campaign that was done by that time by the Bavarian State Ministry of Health and Care. And the release was also accompanied by additional campaigns done by the German Heart Foundation and also the Techniker Krankenkasse and some other partners. And that actually gave HerzFit quite a push, so that we reached several thousand people already within the first days. So let's dive a bit deeper into what HerzFit actually is and how it looks like. I would like to start with the risk calculator because that has been actually the beginning of HerzFit. So first we just wanted to develop that one and then the app grew right around it. The idea is that one of the two main goals behind HerzFit is that we wanted to develop a tool that is a life coach for our users to prevent CVD in the long run. And as you probably might know, current risk scores are quite difficult to understand because they give you something like you have a 15% chance of getting CVD within the next 10 years, which is quite difficult to understand, especially for laypersons. So within HerzFit, we came up with the concept of the heart age, which from the idea is that if you have normal risk factor levels, your calculated heart age would resemble more or less your real age, or if you're very good, maybe even a bit lower. But if you have elevated risk factor levels, then your heart age would be above your normal age. And that will tell you that something is off and you should maybe check. So internally, HerzFit uses 4 different risk calculators that we combined into one, so 4 different scientific scoring systems, because we wanted to enable risk calculations for all of our users, covering a very broad age range from 18 until, well, I don't know, something like 120 years, and also different risk factors such as diabetics versus non-diabetics, or CVD patients versus non-CVD patients. But of course, this is not all that HerzFit offers. HerzFit has a lot of other functionalities that I want to go quickly over. We have a very big part of HerzFit that is all about monitoring your health data. Users also have the possibility to connect their wearables on Android devices through Health Connect and iOS devices through HealthKit. And that enables them to automatically sync all of their wearable data into HerzFit. And of course, users can also at any time choose to manually input their values. Then the second big part of HerzFit is all about educating about different lifestyle factors in the categories of nutrition, stress management, physical activity, and also smoking cessation. That one was mainly developed with the German Nutrition Society and also with the Apothekenumschau, and covers a wide variety of different tasks that users can do, such as reading articles, but also little challenges like integrating whole grain products for a week. And then the last part, that one is mainly curated by the German Heart Foundation, is all about just giving information on all different topics about health and disease, such as, I don't know, nutrition, recipes, physical activity, medication. So there is a lot of content just to read about. All right, so that brings me to the second question of our presentation. Do we actually reach the target population that we want to reach? So 2 weeks ago, I checked again, and we were at more than 145,000 downloads. So I would definitely answer that question with a yes, we do reach the general population through HerzFit. And moving forward, I would like to take a step back to the statement that we saw in the beginning of our presentation by Professor Lauterbach. And I think the key part of this statement is that we need to target risk factors, that we need to identify them early and target them better. So we actually have a second goal of HerzFit that we haven't mentioned before, which is to enable HerzFit to be a tool also for scientific data collection, to be able to generate data about the users that use HerzFit and use that to gain deeper insights into primary prevention and also secondary prevention, but especially primary prevention, because that is an area that is not so well researched until today. So the second or the third question that we want to look at as part of this presentation is, do we reach the individuals at risk? And this is where I first want to introduce you to the concept of data donations that we integrated into HerzFit. We built a module for that. And this looks quite easy on the slide, I think, but it was actually a rather big legal challenge, because we have a very specialized setup in here, because we don't own HerzFit as a research institution. HerzFit is currently owned by the German Heart Foundation, and whoever is familiar with the General Data Protection Regulation knows that data sharing between different institutions always comes with some challenges, which is why we decided to enable to make data donations from HerzFit anonymous, because anonymous data isn't considered as personal data by the GDPR, and therefore it can easily be shared. The second big problem that we had because of the setup is that every data that gets sent via the internet is associated to a so-called IP address. And that one, back in 2023, was considered personal identifying information. So we couldn't send the data directly from HerzFit to us, because we weren't allowed to do so without any additional contracts. Which is why we came up with the concept of a so-called de-identification proxy, which just does one thing: it takes the data from the user and forwards it to us as research institutions. And the final system looks like this. So we have, of course, HerzFit that collects data from the users, and then we also have a content management system that covers the news articles that you saw before. And because we have this content management system that also transmits information through the internet, HerzFit users already have an agreement with the German Heart Foundation that they're able to process their IP. So we use this to then introduce the de-identification proxy, which comes into place once a data donation is started. So first, the data gets encrypted and anonymized on the user's device, and then sent to the de-identification proxy using the IP address of the user, which, because the de-identification proxy is operated by the Heart Foundation, isn't a problem because they're legally allowed to do so. And then the de-identification proxy just forwards it to us using its own IP address, and we never know about the IP address of the users, but only about the one from the Heart Foundation that is completely fine to know for us. So this works. It has been in place for over a year now. We have been receiving more than 8,000 data donations since then. And a little fun fact, and I think this is important to stress at this point because it's also part of research, I emphasized 2023 before, because actually in December 2023, the European Court of Justice changed their ruling so that IP addresses are no longer considered personal information anymore, so that in theory, the whole setup that we took very long to come up with and to implement wouldn't be necessary from a legal point of view right now. We still decided to keep things in place because it comes with additional security benefits, and also whoever knows about IPv6 that might rise and come again with challenges that could go into identification again. All right, but so much for the technical concept behind the data donations. We now want to look at the actual data that we generated through the data donations, and I will hand back to Fabian for this.
All right, so we now look at a cohort of 2,274 HerzFit users, because for this cohort we can provide pretty detailed insights into medication and disease status. So first of all, you can see that the majority of our users is in an age range of somewhat 45 to 75 years. We can also see that actually most of our users are male. And one thing that was quite interesting for us is that the majority, more than 70%, are still in primary prevention, meaning they do not have a cardiovascular disease yet. So apparently we have a population where we can still prevent incident cardiovascular events. For those who are already in secondary prevention and suffer from cardiovascular disease, the absolute majority suffers from coronary artery disease, meaning they already had a heart attack, a bypass surgery, or a stenting. If we now have a closer look at risk factor awareness, we chose to focus on two of the most important risk factors that we do know. It is blood pressure or elevated blood pressure and cholesterol levels. And if we look at the first figure, we can see that both in primary, the green column, and secondary prevention, most of our users did know their blood pressure levels. So of course we have a bit of a bias in our group, but still that is actually pretty great. And maybe that's the consequence of routine blood pressure measurements in GP's offices or at pharmacies, or maybe someone just at home has a BP measurement device. On the other hand, if we now look at cholesterol level awareness, we can see that even in secondary prevention, less than 50% did know their cholesterol levels. This is not that good. If we now have a closer look at primary prevention and categorize the people into different risk categories according to the current guidelines, we can see that especially, or still in the group with the very high risk group, meaning with a really substantial risk of developing a heart attack or a stroke within the next few years, less than 50 or close around to 40% did know their cholesterol levels. And if we finally look at the smoking cohort, and especially at the current smokers marked by the red column, we can see that it's exactly the current smokers that already have an increased risk that were least likely to know their blood pressure or their cholesterol levels. So this is actually something that we see in clinical practice every day. Someone presents to the ER with a heart attack and he or she is an active smoker. And then we ask them about cholesterol control, medication, blood pressure levels. And in many cases, they do not know that much about it. And in many cases, it turns out that they do not have one risk factor, but further risk factors that are all badly controlled. So I would say there is definitely potential for improving risk factor awareness. If we now want to speak about risk factor control, we have to focus on the cohort that did know their cholesterol or blood pressure levels, so the cohort now gets smaller. And as you can see, most of our users in primary prevention was in moderate or high risk of developing a cardiovascular disease. And now we use the targets, the treatment targets that are recommended by the guidelines. And as you can see, especially in secondary prevention and in the high-risk cohorts, only a minority of the users did achieve the targets that are recommended by our guidelines. And if we now look at those who are on medication, so first of all, you can see a good thing, because in secondary prevention, almost everyone was on statin therapy. That is good because that is guideline recommended. But if we now look at cholesterol control, we can see that even when on medication, only a minority achieves the targets that are recommended. And of course, we do know that the targets are quite strict, but they are strict because we do know the better the control of the risk factors, and in this case of cholesterol control, the lesser the probability of developing a first or the next cardiovascular event. Secondly, we took a look at blood pressure control. So first of all, we can see that around about 60% of our user population actually has a blood pressure value that is within the range of the latest guideline of the ESC, which is pretty strict. And we also can see that, once again, around 60% are on medication. And one thing that is interesting is that only 50% of those individuals who are already on medication achieve the treatment targets. So there is not only potential for improving risk factor awareness, but apparently also for risk factor control. So we cannot only blame the people that they are not aware of the risk factors. Apparently it's also a bit of a problem in terms of treatment efficacy. So with this, we would like to summarize our presentation for today. I think we have developed an app that is able to raise awareness for prevention, which is important, an app that reaches the people, or at least 145,000 people so far, and we can reach individuals at risk. So the thrilling question for the future will now be, can HerzFit also encourage its users maybe to live a healthier life and even to better take care of their risk factors? And at least the two of us are pretty excited to be able to answer this question within the next few years. And with this, we would like to say thank you to everyone who is involved in this project and to you for your attention.
Thank you very much. We have a panel discussion in the end, but if there are directly questions to the talk, I think we can, or we should, take them now. I have one question in order to follow. If a user is changing his habits or is influenced by the app, can you link when you download the data in a year again? Do you know who is who?
Yes.
So we actually, we're legally not able to introduce an identifier because that would make it re-identifiable, but we have an algorithm that uses something like birth date and gender, and then takes into account whether a big majority of the last donation matches the actual donation to sort of create a mapping. So we are quite confident that we can link those data, yes.
So, but it's this method is approved. It's not a way to.
It's approved by the data commissioner, so they said yes.
Okay, thank you.
Thank you for your presentation.
Can you switch on the mic?
Thank you for your presentation. I have a question regarding the female use of the app. Why do you have less female users, and could you encourage women to use the app more?
That's actually a quite good question. I only came up with one idea. It's sometimes in clinic we see that women more often encourage the men to go to the clinic when they have symptoms of chest pain, for example, and it's not the other way around. Maybe this is some sort of the same reason that just women take better care of the men than the other way around, but I do not have a better answer for this yet. So we would love to have more women in our app, of course.
I could also imagine that it's because in the generation that we're interested in, probably more men are digital, like to use smartphones and probably try it more, but this is just a claim and we don't have any data.
Yes, I also have a question regarding how do you want to measure the effectiveness, the medical effectiveness of HerzFit, and how much can you orient at what is standard with a DIGA procedure?
Well, so I mean, we're gonna get data. So for a few users, we already have data for further months, or I think our data donation is every 3 months. So for some, we already have the 4th data donation by now. I think one of the problems is that in contrast to DIGAs who only focus on a very specific topic, such as blood pressure control, where it is easier to show that you have a benefit. Our disadvantage is that we just focus on all the cardiovascular risk factors, so it will be a bit hard for us to show an effect on specific risk factors. Maybe it's more of a general effect of raising awareness, and I would be a bit cautious to say that we're gonna get everyone to take better care of their blood pressure. I think it's just pushing the people in the right direction. But we are also planning on doing further research in this regard. And for the DIGA, as Lara already has mentioned, at this moment we are not a DIGA. One of the reasons is that the app is owned by the German Heart Foundation and is available for free, and this was always our intention. And to really make the step towards a DIGA is a lot of money and is building an enterprise. So that's just not feasible for us at the moment. And I think this is rather a decision that the German Heart Foundation has to make one day, but at the moment they are not willing to do so.
My question was pointing to the DIGA process to prove medical effectiveness of the DIGAs. How much can you take this into account into your attempt?
Yeah, well, once again, so basically we would have to prove that we are effective in reducing the number of cardiovascular events, which is, I think, harder than proving that blood pressure control gets better. So I'm not sure if we could get like a general DIGA for cardiovascular prevention. It would be probably easier just to focus on one of the topics that we have in HerzFit.
Yeah, you have nicely shown that quite a few people are not at blood pressure or cholesterol targets. So are there any options to build an alert saying that once, this is evident that there's a patient with a heart attack in the history and not reaches cholesterol or blood pressure measurements or targets, just to have a pop-up showing that there is need for action?
So when people click our risk assessment test, they get some sort of recommendations at the end. So we have to be a bit cautious with our recommendations because we are not a DIGA and we do not have doctors in the back end all the time. So if we see that the blood pressure, for example, exceeds, back then it was 140/90 still, then we send a warning that the blood pressure is not ideally, and maybe you should see your doctor and speak with him about medication. The same for cholesterol levels, the same for lifestyle parameters such as inactivity. We cannot give drug recommendations, of course, because we're not a DIGA, but we try to go another way around.
Okay, I think we have to move on. Thank you very much for this nice introduction for the HerzFit. Thank you very much. We will then, so I will focus on the genetic screening of the analysis of the first 16,000 participants. Just to recapitulate again, so these numbers from 16,000, there is a first screening of all the children who participate on LDL cholesterol, and if they are above a certain threshold, which is in the end, we defined 130 milligram per deciliter, it's 7% of all children, they will undergo a genetic screening, and we decided for a sequencing, NGS sequencing of 23 candidate genes, including 4 genes which are known to be relevant. And in 16% of these children, we do identify a known pathogenic variant or a variant which has a clear impact on the function, which can be then diagnosed as familial hypercholesterinemia. It's interesting when we, and this shows the power of the study design. When we compare the VRONI study, which we performed on children, with a study which is performed on adult, you can see that in the children we have a window where the environmental influence is much less pronounced than in adults. So if you do the same study in adults, you define a threshold with a 92nd percentile, you find less than 2% mutation carriers. But when you screen in children, you have 16% of mutation carriers, because here the other factors which are important for the LDL cholesterol are less pronounced than the genetics. But the genetic if you have a mutation in the LDL receptor, for example, your risk is 20-fold increased. While if you have just increased LDL cholesterol, it's only increased 4 or 5-fold. So it's a very important risk assessment if you have familial hypercholesterinemia or just increased cholesterol. So it's the screening is also now very important for the parents, and we was introduced the cascade screening also to identify the parents at risk. And another point which I would like to point out is that if you compare it with the study from Wald, where we have only where there was only investigated a number of frequent SNPs instead of sequencing, also here the result of the detection rate was much lower. So we have to do the sequencing, and this is also shown in the next slide. Because we have genetic variability from areas, ethnicities. So in Bavaria, we have identified founder mutations which explained a large fraction. And these founder mutations have not been included in the most frequent SNPs which were defined worldwide. And now I would like to ask Devi to come up, that you see the person who is doing the genetic screening, and maybe you want to, when you have later questions, you can ask them to Devi. This was a very important project of her PhD, which she just submitted recently. So, so I present your data, Devi. Yeah, and Devi was also looking in the data. We have the information of family history or other risk factors. It wouldn't change the screening, so it doesn't make sense to measure twice the LDL cholesterol for the clinical definition of hypercholesterinemia, or to look from the family history. The efficiency of the screening is in this way the most efficient. And with this, I would like to thank you, and I'm happy to take your questions.
I start with the first question, and the question is, what happens with the 84% which do not have a dedicated FH mutation? How are they investigated regarding the cause of the LDL level, and how are they treated?
So there are multiple ways. So one of the first ones, and also one of the well-known ones, is polygenic risk scores. So all of these patients with hypercholesterolemia are also genotyped, and we assess the polygenic risk score, and we do find in roughly 15% and these are very stringent criteria, then we do find a polygenic cause of the disease. Additionally, I mean, the panel that we do or the sequencing that we do for monogenic causes, it's not just the 4 genes that we do report on, but it also covers in total 25 genes which are involved in the lipid metabolism. So also there we are covering candidate genes, and we're looking for variants that might cause the disease. And then we also tried some genome sequencing in very high and very low LDL cholesterol cases. But so far, we might be that the numbers were too low, but we couldn't find a cause. Yeah.
Maybe I can add one more detail. We started to do lipidomics and metabolomics to better understand the background of the LDL cholesterol level. So there is some research in the future coming to better understand this. And as Vero already mentioned, there is also a treatment suggestions for those which do not get statins, but to fight against the high LDL cholesterol.
What is the reason for the parents not treating their children with this FH medication? The like 10% I've seen on one of the first slides.
Maybe I can answer. The reason for parents not to treat their children is often, and we have, this was very impressive because the pediatricians are saying, look, this is adulthood disease, we can wait until the disease comes. So there is a misunderstanding of the concept of prevention here.
I think 90% are excellent. If you go to patients who suffered from a myocardial infarction, you won't achieve 90%. I mean, they have even a better reason than these children. So the question for me is, I mean, we arbitrarily picked this 93 or third percentile. Now, looking at all the data, what would you think in this age group would be a reasonable cutoff for genetic screening, which comes with costs and logistic challenges? Is it the 93rd percentile, or is it 95th and 99th percentile?
I think it's depending on what is the question. So how it's a cost sensitivity calculation, and I did some analyses, and we do see when we screen with 130 milligram per deciliter, and we would just screen the lowest number of people, so 130 to 135, we still do have a diagnostic rate of 4%. So considering that the prevalence is now 1 in 150 currently in VRONI, we still have an enrichment. So it's really a cost calculation that we so far didn't do, and for which also more information is needed on the money or cost level. Yeah.
So our judgment was that the effort is quite high until we come to the point of sequencing, and when we move from 130 to 140, there is a larger group, but still several-fold enriched for mutation carriers. So we think the cost for the sequencing is not so high that we would skip it. So we, in the end, we have our conclusion is it was a very well-defined threshold. Okay, thank you very much. Moritz, you have the last presentation in the DigiMed project, and we have already heard about the chip and how important it is, and that there is even some clinical trials for translation. So now we happy to learn more about the background.
Thank you for the kind introduction, Holger. So it's my pleasure to talk about the relevance of clonal hematopoesis of indeterminate potential, short chip, so it's easier to digest as chip. For our use case, it's specifically focused on patients with developed CAD and focusing on mortality risk here. So what is the relevance of chip? So you heard about chip in two different talks today, so I keep it short. The definition is an acquired somatic mutation in the hematopoietic stem or progenitor cells that comes with an advantage for these cells to expand clonally. And by definition, it's an acquired mutation, and there is need of a specific threshold of a mutation load defined with a variant allele frequency of over 2%. So the whole story for the cardiovascular field looking into CHIP started 10 years ago, and this was a key publication of the group of Professor Sid Jaiswal from Stanford group, and he showed two interesting novel things. The first is this is whole exome sequencing data with a low depth, so they did not look too deep to DNA. They saw this is age dependent, so it's increasing dramatically during the aging process. This is the first message, and the second is they expected it to be associated with cancer-related mortality, but it was not. But it was related to cardiovascular related mortality, and the higher the variant allele frequency, so the mutation load, the higher the risk for the mortality. And in the very same publication, they showed the incident risk to develop coronary artery disease, and this is data from the Jackson Heart study and from the Fusion study, and compared it to the classical risk factors. And here you can easily see that the risk that derived from these somatic mutations is higher than those of the classical risk factors. And they provided it for the high variant allele frequencies in this table. But if you go for all CHIP, then it's around 3.5, so comparable to type 2 diabetes if untreated. So what hypotheses did we follow up in the last 4 years? basically, we wanted to show that patients with CED and CHIP are at increased mortality risk. We wanted to show that this increased risk is based on a more complex atherosclerotic phenotype, and that the underlying mechanisms are mainly driven by inflammation. Therefore, we studied CHIP-affected macrophages to dissect potential novel mechanisms here. So this, you saw before, one of the key upregulated inflammatory pathways is, at least for the common CHIP mutations, the NLRP3 inflammasome, with caspase-1 as the central enzyme, and the effector cytokines interleukin-1 beta and interleukin-18. And what we'd like to show is in dark blue, these CHIP-mutated cells that release to the blood flow, that they are able to go into the arterial wall and increase basically the local effects for atherosclerotic development. So I'd like to start with our human clinical data. So we screened in the last 2 years around 10,000 individuals, and this was the first batch of 8,700. And for looking at the mortality risk over 3 years, we excluded all individuals with a variant allele frequency below 2% by definition. However, there's an effect with a follow-up of less than 1.5 years and missing covariates. So basically, we had around 2,000 CHIP positives, and all except one could be matched using a one-to-one propensity score matching k-nearest neighbor method to a non-CHIP mutation carrier. So we were able to pinpoint it as good as possible to the CHIP effect. So here you can see the variables of the unmatched cohort. So in the mean age of a CHIP mutation carrier is 5 years more or older than a non-CHIP mutation carriers. And after the propensity score matching, you can see that you are losing completely the age effect and the other risk factor effects. So we're very close to the effect of CHIP here. And this is the mortality risk for the all CHIP mutation carriers across 3 years. In blue, the CHIP positives, in yellow, the CHIP negatives. And what you can easily appreciate is that CHIP drives mortality risk in these CED patients. Then we wanted to know what is the effect not for the all CHIP mutation carriers, but for those with a very high variant allele frequency, defined over 10%, so high mutation load. And what you can see is you increase the risk. So the relative risk was 1.48, and here you can see it doubles up for the high mutation loads. And 1 out of 3 of these CHIP mutation carriers has high mutation load. So very relevant. Pinpointing it to the individual genes, we used a 13 gene panel, and you see these are the 3 most common ones. So DNMT3A, TET2, and A601 account for around 70% of all CHIP mutations. And what is interesting to see, at least for me, is that all the CHIP mutations are driving the mortality risk. And for those that are marked bold, we have a significant effect on mortality for this single gene, which is novel. And if we only look for the variant high allele frequencies, 2 more genes became significant. However, the power is very limited down here. So this was the clinical part. Now I would like to look at the basic research part, and we established a very nice post-mortem biobank called Mission, starting in 2019 in collaboration with the Forensic Medicine Department of the LMU. And what we collected is, from more than 1,500 individuals so far, several cardiovascular relevant tissues. So we have the opportunity to take from the coronary tree 7 different areas: the main stem, the proximal, and the distal area of each coronary, both sides of the bifurcation of the carotid, liver, skeletal muscle, epicardial fat, subcutaneous fat, heart muscle, blood, plasma. So a full spectrum of the patient that allows to also look across organ borders. And we did CHIP status of those 1,500, and more than 350 were CHIP positive, so CHIP mutation carriers, where we had then the opportunity to look also in the tissues. So here you can see the heart before and after the autopsy. Then these are the segments of the coronary tree which are explanted. And then we have a high-resolution slide scanner that allows us to do FFPE stained slides to digitize those. And if you think that we have 9 different areas of the arterial tree, basically, you can multiply. So around 50,000 individual stained sections are possibly available in the Mission Biobank setting. And as you cannot by hand characterize these 50,000 images, we developed in collaboration with a group of Dr. Ma at the Helmholtz Center a deep learning model called Unicorn, allowing us to classify each of these different disease stages to AIT, PIT, EFA, LFA, and the calcified fibroatheroma. And this helped us to not only bring these into the class, but also by visual output allows us to identify if this classification is correct or not. And these are exactly the highlighted areas where we look at if we classify these plaque types. So what I'd like to show you, as we wanted to show that these chip mutation chip-mutated leukocytes have the potential to invade into the human atherosclerotic plaque. Here, this is what you would call more on the healthy side, and here is the pro-inflammatory shoulder region of the plaque. And in this shoulder region on the neighbor slide, you see a lot of CD68 positive macrophages, so the effector cells in the human plaque. And on the left side, this is fluorescence in situ hybridization for single point mutation in the DNMT3A gene, which is also or the most common chip mutation. And focusing on this specific cell, this was the very first chip-mutated leukocyte that we were able to visualize in the human atherosclerotic plaque. To better dissect the functional aspects in the human coronaries, we took from this Mission Biobank 26 TET mutation carriers against age and sex-matched controls. We took the proximal part of the left anterior descending coronary artery, and by histological assessment, it became clear that more complex CED is present in these TET2 chip mutation carriers. And to understand it on the functional level, again, with the help of the group of Professor Mann, with Sophia Steigerwald and Ankit Sinha, mass spectrometry was performed on the exact left anterior descending parts. What you can see is after enriching the proteins, in blue the biological pathways, in yellow the cellular compartment and the molecular function, that specifically pathways associated with inflammation, immune response, but also with metabolism, lipid metabolism, are elevated. And one pathway I like very much is the leukocyte migration involved in inflammatory response. Another finding we had is that the inflammatory pathways are closely correlated with the lipid metabolism pathways, and this will be relevant in the future slides. Just a short highlight regarding the plaque stability, as pointed out by Professor Magdefessel. This is core, so patients with unstable plaques are at higher risk for myocardial infarction and stroke. And when we looked at 3 markers, including caspase-1 as the central enzyme in the inflammasome of the NLRP3, you can easily appreciate that this is elevated in these chip mutation carriers. The same is true for collagen 14-8, which is associated with plaque stability. This is downregulated in the chip mutation carriers, and the same is true for integrin beta 3, which is also a plaque stability marker, which is also downregulated in the chip mutation carriers. So in conclusion, TET2 chip status is associated with atherosclerotic plaque instability. So we would like to show you that also the effect in the effector cells, in this case the macrophages, can be made usable. So we joined forces with the StarNet Biobank, which holds more than 1,000 coronary artery disease patients that underwent CABG, so bypass surgery. And when we correlated the TET2 chip status with the clinical traits, we see a very strong correlation to atherosclerosis, complexity of CED, and coronary artery disease burden in general. When we compare the RNA sequencing of these macrophages, there's a lot of perturbation, and if we enrich it again on pathway level, we see that pro-inflammatory and immune system-related pathways are upregulated. So in conclusion, TET2 chip status in human monocyte-derived macrophages is associated with atherosclerosis, CAD complexity, and upregulation of inflammatory pathways. And this is the last slide, then you are all done. This is in vitro macrophage data. This is in collaboration with the Stanford group of Sid Jaiswal and Nick Leeper. And Shaunak Atka performed these experiments, and what he did is he used human monocyte cells, differentiated those into macrophages, and then stressed them with this either LDL or OXLDL. And what you can appreciate that these TET-mutated macrophages take up more LDL and OXLDL compared to the non-mutated. So in conclusion, TET chip status in human macrophages is associated with increased inflammation, but also with increased uptake of LDL and OXLDL cholesterol in vitro, which would have a clinical implication, of course. So to conclude, CHIP is the strongest potentially modifiable cardiovascular risk factor we know. For the common or most common genes, it's driven by inflammation. We established so far the largest single-center CHIP CAD cohort worldwide. CHIP is very common. So one out of three CAD patients at the German Heart Center was CHIP positive, and it's depending on the depth of the sequencing. So in the early years, they missed around 50% of all CHIP mutations because they only sequenced with a depth of around 30-fold. We visualized CHIP-mutated leukocytes in human atherosclerotic plaques. TET2 CHIP status was associated with upregulation of inflammatory and metabolic pathways and plaque instability. We saw that macrophages affected by TET2 CHIP were associated with CAD complexity, and these macrophages showed increased LDL and OXLDL uptake. So what is the clinical perspective here? To us, it appears very likely that TET2 chip mutation carriers might particularly profit from anti-inflammatory therapy as well as from a very aggressive lipid-lowering treatment strategy. So regarding prospective studies, we pointed out this phase 2 trial, which is almost over. We have event-driven trial in mind, so this would be a phase 3 trial that hopefully starts during the next years. This would be a guideline-relevant clinical outcome trial with around 2,000 individuals. And to provide guidance, we established in collaboration with the hematologic partners at the Rechts-der-Isar the German CHIP registry with more than 2,500 active participants. And this is only possible with a very strong team. I'm very thankful for everyone who contributed, and thank you for your attention. Thanks.
Thank you very much for this impressive, comprehensive analysis and also deep going into the mechanism. Are there any questions? Maybe, there's one.
So you showed that 1 out of 3 patients potentially is a CHIP carrier, and we also already got a recommendation. I think it's level 2A for colchicine. So when do you think will we really start to treat patients with anti-inflammatory drugs? Because, I mean, so far, at least in my experience, we are not really doing it.
Yeah, so it's a to-be recommendation, and we started to treat very selected individuals. This is covered, and the FDA approved it in the US, and we do not see that they are starting aggressive anti-inflammatory treatment. What we would need is, and they are doing retrospective analysis of the COICOT and the LUDOCO 2 trial right now, and this would be good information to see what risk reduction can be expected on top as for the general CAD patients for the CHIP mutation carriers. We would expect around 20% relative risk reduction here. Regarding anti-inflammatory substances, there is several, of course, interesting possibilities. Colchicine is one, canakinumab is the other, novel upcoming combined antibodies or an interleukin-6 antibody. All of this is something we would like to focus on during the next years, but there is no guideline recommendation regarding screening or treatment of CHIP mutation carriers yet. However, yes, if I would be a CHIP mutation carrier with a TET2 mutation, I would take colchicine.
Julian?
Yes, hi, thanks. Very great talk. Are there other relationships between leukemia and GAD?
That's a very nice question. So I gave Dr. Crafting in the auditorium a hard time because we tried to look into 2.4 million insured individuals from the AOK if there's a connection between a cancer status and cardiovascular outcomes. And so the shared or potentially shared mechanism we would think of is inflammation. And we see for lung cancer and digestive tract cancers a signal that there is increased mortality, stroke, and MI risk combined in a MACE outcome. Yeah. So I would think that some certain kinds of cancer would increase your cardiovascular risk. Yes.
I was wondering, you showed in the beginning that started with the observation that the percentage of chips is increasing with age. Did you have ever a follow-up of your patients to sequence them at different time points to see how the mutation load of your mutant of interest is changing?
Exactly. This is what the chip registry is meant for. So they have annual checkups in collaboration with our hematological department to see how the mutation load and the clones develop or not. This is important, yes. So the registry allows us now to have longitudinal data on these individuals.
But so far there are no first results saying something.
Actually there are. So the problem, or not the problem, is so I recontacted the persons after having the DNA in hands for years. So we have around 3 to 5 years of follow-up because we have the first DNA sample from our biobank. And we see from the first 500 that have been basically sent to the hematological department that there is progression, and there seems to be progression for specific genes in general. So they are more likely to expand the clone size. And there's patterns, like there's specific combinations of genes that come together more common as you would expect from basic statistics. And this is interesting to see. So for example, DNMT3A is the most common, but it usually comes not with a second mutation. However, TET2 and A6L1 come together quite often. And this is something we try to dissect with the hematological department right now. But there is progression, yes. So it makes sense to have regular checkups of these individuals over time.
Now I'm thinking if there is progression and you have different risk profiles depending on the minor allele frequency or the proportion, so can you correct this, or is this inside the risk prediction?
This is something we would like to answer. We can't yet. But exactly this is something that drives us. Yeah. No data yet.
Okay. If there are no other specific questions, I would like to ask, because we have some.
Quarter to 3. So what's the time schedule? Are we in time? Are we over time?
I saw.
Bit over.
10 minutes. So coffee break.
Then we go to the coffee break. Yeah. Thank you very much to everyone again.